Imagine a scenario where a new virus emerges. It doesn't just cause a cough or a fever, it attacks the brain. It causes seizures, personality changes, and within 48 hours sends patients into a deep coma. Now imagine that for every 4 people who catch this virus, 3 of them die. We aren't talking about a 1% mortality rate like we saw with the early strains of COVID-19. We are talking about a mortality rate that ranges from 40% to 75%. This is not the plot of a Hollywood disaster movie. This is the reality of the Nipah virus. It is real. It is currently circulating in parts of Asia, and the World Health Organization has listed it as one of the top priority pathogens that could cause the next global pandemic. The world has been so focused on respiratory viruses that we have largely ignored the neuroinvasive threat waiting in the wings. Today, we are going to break down exactly what Nipah is, how it jumps from bats to humans, why it is so incredibly deadly, and what we need to do to stop it from becoming a global catastrophe. Before we unlock the biology of this terrifying virus and discuss the reality of the threat, I have a small but important request. We are dedicated to bringing you raw, unfiltered, and scientifically accurate medical information that the mainstream media often glosses over. To help us keep doing this work and spreading vital awareness, please hit that subscribe button right now. Turn on the notification bell so you are alerted the moment we release a new briefing, and please like this video and share it with everyone you know. Knowledge is our best defense against disease, and by sharing this, you are helping to build a wall of awareness. I am Dr. Aria Wells, and today we are analyzing the Nipah virus. To understand why virologists lie awake at night worrying about Nipah, we have to go back to 1998 in a small village in Malaysia called Sungai Nipah. Pig farmers started collapsing. They developed high fevers, but unlike the flu, they became aggressive, confused, and unable to balance. Then the seizures started. Initially, doctors thought it was Japanese encephalitis, a mosquito-borne disease common in the region. They sprayed for mosquitoes, but the cases kept rising. It wasn't until a diligent researcher looked at the tissue samples under a microscope and realized this was something entirely new. It wasn't coming from mosquitoes, it was coming from the pigs, but the pigs were just the vessels. The true source was the flying fox, a massive fruit bat that carries the virus without getting sick. The bats ate fruit in the trees hanging over the pigsties, dropped half-eaten fruit contaminated with saliva and urine into the pens. The pigs ate the fruit, amplified the virus, and passed it to the farmers. That outbreak was stopped only by the tragic culling of over 1 million pigs. But the virus didn't disappear. It just retreated back into the shadows of the jungle. Since then, we have seen sporadic, terrifying outbreaks in Bangladesh and India, specifically in the Kerala region. And here is where the story shifts from pig farming to something much harder to control. In these later outbreaks, there were no pigs involved. The virus jumped directly from bats to humans through a local delicacy, raw date palm sap. People place clay pots on palm trees overnight to collect the sweet sap. The bats, loving the sugar, fly to the pots, drink from them, and urinate or defecate into the sap. The next morning, unsuspecting people drink the fresh juice, ingesting a massive viral load. This is the nightmare of zoonotic transmission, nature and human habit intersecting in a deadly way. So, what happens when Nipah enters the human body? This is where the difference between Nipah and COVID-19 becomes stark. COVID-19 primarily attacks the ACE2 receptors in your lungs. Nipah targets a receptor called ephrin B2. This receptor is found in the endothelial cells, the lining of your blood vessels, and critically, in the neurons of your brain. Once the virus enters your bloodstream, it effectively punches holes in the blood-brain barrier. It causes a condition called encephalitis, which is severe inflammation of the brain tissue. The symptoms usually start innocently enough: fever, headache, muscle pain, vomiting, and a sore throat. It looks like the flu. This prodromal phase can last anywhere from 3 to 14 days, but then the neurological phase hits, and it hits hard. Patients experience dizziness, drowsiness, and altered consciousness. They might not know where they are or who they are. They may become combative. This rapid deterioration leads to acute encephalitis. Within 24 to 48 hours of these neurological signs appearing, a large percentage of patients slip into a coma. The brain is swelling against the skull, causing massive damage. But the horror of Nipah doesn't end even if you survive the acute phase. We have documented cases of relapsing encephalitis. This means a patient can recover, go home, live their life, and then months or even years later, the virus, which has been lying dormant in the central nervous system, reactivates. The brain swelling returns, and the patient can die years after the initial infection. We also see late onset encephalitis, where someone might have a mild initial infection but develop severe brain issues down the road. This viral persistence in the brain makes Nipah a uniquely difficult enemy to fight. Now let's address the elephant in the room: transmission. If this virus is so deadly, why hasn't it wiped us out yet? The saving grace of Nipah so far is its R0, or reproduction number. In most outbreaks, the R0 is less than 1. This means that, on average, one sick person infects fewer than one other person. The virus burns itself out because it kills its host too quickly to spread widely. COVID-19, by comparison, has a lower death rate but a very high transmission rate, allowing it to spread everywhere. Nipah is currently not airborne in the way COVID or measles is. It requires close contact with body fluids, blood, urine, or saliva of an infected person or animal. However, and this is a massive however, we have seen human-to-human transmission in Bangladesh and India. It usually happens in hospital settings or within families caring for sick relatives. If a patient has severe respiratory symptoms, coughing and expelling droplets, the risk of infecting caregivers is high. The reason WHO lists this as a priority, is mutation. RNA viruses like Nipah mutate. If Nipah were to mutate to become more easily transmissible between humans, perhaps becoming truly airborne while maintaining even half of its current lethality, we would be facing a biological event unlike anything in modern history. A virus with the transmissibility of the flu and the lethality of Ebola is the worst-case scenario for global health security. Currently, there is no licensed vaccine for Nipah virus. There are candidates in development utilizing similar mRNA and viral vector technologies that were used for COVID vaccines, but none are ready for mass deployment. There is also no specific antiviral treatment. The only management is supportive care, keeping the patient hydrated, managing the fever, and trying to control the brain swelling and seizures. We are essentially trying to keep the body alive long enough for the immune system to fight a war it is ill-equipped to win. There have been compassionate use trials of monoclonal antibodies, specifically one called M102.4, which showed promise, but access to these experimental drugs is extremely limited and usually not available in the rural areas where outbreaks start. So, how do we prevent this? Since we cannot eradicate the bats, and we shouldn't, as they are vital pollinators and essential for our ecosystem, we have to change human behavior. In outbreak-prone areas, the message is clear. Do not drink raw date palm sap. If you boil the sap, it kills the virus. It is a simple heat kill step that saves lives. We also need to keep farm animals away from fruit orchards. We need to wash fruit thoroughly and peel it before eating. If you see fruit with bite marks or scratches on the ground, do not touch it. Leave it alone. It likely fell because a bat was eating it. On a broader scale, we have to look at the concept of One Health. This is the idea that human health, animal health, and environmental health are linked. Every Nipah outbreak has been driven by ecological disruption. When we cut down forests for palm oil plantations or pig farms, we stress the bat populations. We force them out of their natural deep forest habitats and bring them closer to our villages and our food sources. A stressed bat sheds more virus. By destroying the buffer zones between wildlife and civilization, we are inviting these pathogens into our homes. Preventing the next pandemic isn't just about building vaccines in a lab, it is about preserving the ecosystems that keep these viruses contained in the wild. I want to compare the psychological impact of Nipah versus COVID. With COVID, the fear was widespread, but the personal risk for a young, healthy person was statistically low. With Nipah, the fear is absolute. In the Kerala outbreaks, the panic was palpable. When a virus kills 3 out of 4 people it touches, entire communities freeze. Doctors and nurses, the bravest among us, are at the highest risk. In fact, in past outbreaks, we lost heroic nurses who cared for patient zero before they knew what they were dealing with. This virus demands a level of infection control and PPE that is difficult to maintain in resource-poor settings. Let's dig deeper into the long Nipah concept. We talk about long COVID, but the sequelae for Nipah survivors are devastating. Studies have shown that over half of survivors suffer from persistent neurological deficits. We are talking about chronic fatigue, personality changes that can destroy marriages and families, and significant cognitive decline. The virus scars the brain. Even if you survive the acute phase, you may not return to the person you were before. This is why the argument that natural immunity is better does not apply here. You do not want to naturally fight a virus that melts your brain tissue. Is there good news? Yes. The good news is that Nipah is not currently spreading silently in the way COVID did. With COVID, you can spread it while asymptomatic. With Nipah, transmission generally occurs when the patient is visibly, severely ill. This makes containment easier. If we can isolate the sick person immediately, we can stop the chain of transmission. Contact tracing works very well for Nipah because the circle of contacts is usually small, family and healthcare workers. This is why rapid diagnosis is key. We need better diagnostic tools available in rural clinics in South Asia so that a fever and headache is tested for Nipah on day 1, not day 10. The global community is waking up. The Coalition for Epidemic Preparedness Innovations, CPI, has made Nipah a primary target. They are funding vaccine research specifically because there is no commercial market for it yet. Big pharmaceutical companies don't usually invest in vaccines for diseases that appear sporadically in poor villages. It requires public funding and global cooperation. We are seeing progress. There are phase 1 clinical trials underway. The goal is to have a stockpile of investigational vaccines that can be rushed to an outbreak zone to ring vaccinate the community and stop the spread, much like we do with Ebola. But until we have that vaccine, your best defense is awareness. If you travel to Southeast Asia or the Indian subcontinent, be aware of what you consume. Avoid raw sap. Be cautious with fruit sold on the street that may not be washed. Avoid contact with stray animals. And if you develop symptoms of fever and confusion after traveling, tell your doctor immediately where you have been. Medical history is often the missing puzzle piece that saves a life. It is easy to look at the news and feel overwhelmed by the threats we face, but fear is not the appropriate response. Vigilance is. We have the scientific tools to understand this virus. We know its genome. We know its receptor. We know its reservoir. The mystery is gone. Now it is a race of logistics and behavior. We need to respect the boundaries of nature. We need to support science that monitors these viral spillover events. And we need to recognize that a virus anywhere is a threat everywhere. In our interconnected world, a plane ride can bridge the gap between a remote village and a major metropolis in hours. This video isn't meant to scare you into hiding in your basement. It is meant to arm you with the facts so you aren't swayed by rumors or misinformation. Nipah is deadly, yes. It is a serious threat, yes. But it is also a threat we can manage if we are smart, if we support public health initiatives, and if we respect the delicate balance of our ecosystem. We defeated the initial SARS outbreak. We have managed Ebola outbreaks. We can manage this, provided we don't get complacent. Thank you for giving me your time and attention on such a heavy topic. Understanding these pathogens is the first step in defeating them. If you found this analysis helpful and want to stay ahead of the curve on global health threats, please subscribe to the channel. Leave a comment below. Had you heard of the Nipah virus before, or is this new to you? Stay safe, stay curious, and always respect the science.